So good morning. Thank you for being with us with this symposium sponsored by Medtronic. It's my pleasure and honor, so this is a TAVI symposium, of course. It's my pleasure and honor to present my colleagues and presenters here. Mrs. Marta Stiges, she's a cardiologist from Barcelona. Professor Trieder from Mainz Hospital and Professor Andreas from Vienna. And we're going to try to cover all together the latest evolution based on the latest guidelines and what has generated the latest guidelines, which are not only data that we have been building over the last years, but also the some technical evolutions that will be covered by a presentation, but also by a live case which was recorded at Mainz Hospital in Germany. So to start immediately, I'm going to ask Marta to start sharing with us the latest guidelines that we have all to be aware of. It's a break point, I would say, and you see that our practice as cardiac surgeons is changing a lot already, and it's going to be a U-turn so far. Thank you, Marta.
Thank you very much for the introduction, and thanks for the invitation. So my talk will focus on the new updates of the new European Society of Cardiology and European Cardiothoracic Surgery Society guidelines on valvular heart disease, but particularly focusing on the role of the cardiac surgeons. So I would like to highlight three big novelties, or at least two novelties, globally speaking, from the guidelines. So one thing is that they rely a lot on the central role of clinical and imaging for the assessment of the patients and also regarding the timing of intervention. This is something that has been progressively put into the guidelines and that we have been doing for recent years. But additionally, I want to highlight another very important aspect of these European guidelines, which is the patient-centered approach and the evaluation for the intervention, putting the patient in the center. We will see what that means and what are the implications for our practice. And the third thing I want to highlight, which is the third basis of the new guidelines, is the heart team approach and the heart team evaluation. Definitely this thing, what we started to talk some years ago, the heart team, has come here to stay. And I will try to discuss the reasons why. Definitely we need to work together. It's not only a matter of a cardiologist or of a surgeon anymore. We are a whole heart team with everybody has its role, from the nurse to the anesthesiologist, the geriatrician, etc. And this is highlighted in these European guidelines, but has also been highlighted in the previous, from last year, American guidelines. So they all specifically explain how should the heart team be composed. And of course, in both guidelines, both European and both the American, there is the role of the cardiac surgeon in both of them. In the European, the cardiac surgeon is included as the list of professionals included in this heart team, and also in the American guidelines, which you have on the other, here in this side of the slide, they distinguish two levels of expertise in valve centers, and in both centers, they include the necessity, the need of having their surgical aortic valve replacement. Therefore, there's a need to have their cardiac surgery. Another important thing, which I'm not going to go deep into, regarding aortic stenosis in the guidelines, is the indication for an earlier intervention. And if you go particularly to this last, you see that as a class 2A indication, intervention should be considered in asymptomatic patients with severe aortic stenosis and systolic dysfunction, as defined by an LV ejection fraction below 55%. So coming earlier, the timing of intervention, again based on imaging, as said before. The second highlight, which is going to be the focus of this talk, is the mode of intervention. So should the patient with aortic stenosis undergo TAVI, Tavr or surgical aortic valve replacement. And this, again, is the mainstream of the novelty of these guidelines, similarly to what was released last year in the American guidelines. So again, as you can see here, highlighted, the choice should be based upon careful evaluation of everything by the heart team. So the heart team has a crucial approach, and of course, as you can see at the end, for each individual patient. So what do the guidelines say? Mainly, when you have a patient with severe aortic stenosis and the patient has symptoms or has LV dysfunction, you go for heart team evaluation. If the patient has, this is what the guidelines say, mainly the novelty is the patient has less than 75 years or has a very low surgical risk, patient, the recommendation is surgical aortic valve replacement. On the other hand, if the patient is older than 75 or has higher risk, defined by neuroscore 2 more than 8%, and the patient has anatomical suitability for TAVI, patient should undergo TAVI. But all other patients should indeed can have both approaches. What do the American guidelines, and that should be a heart team decision. American guidelines are quite similar in the approach of the heart team, probably a little bit different in the cutoff of age. So maybe a little bit more aggressive on the indication, more aggressive or more expanded on the indication of TAVI. So the age cutoff is 65 years, and then in the, above 80 prefer transfemoral TAVI, and in between we have this discussion. So what determines what should be discussed in the heart team for the choice of TAVI or surgical aortic valve replacement? First of all, in the end, it's valve durability, the risk of the procedure of a TAVI or a surgical in an individual, the risk of reintervention, and this is important because we have to think on the life management of aortic stenosis, not solving the problem for today, but for the whole life span of the patient. And of course, as also recommended in the guidelines and highlighted in the guidelines, putting the patient in the center and thinking not only what's the best solution for that given patient, which is the role of the heart team, but also asking the patient what are their preferences and share the decision with the patient. Regarding durability, we still have low data, but as this very recent work in 200, very few data on patients with low risk, with low operative risk. So this work has been recently published. It's 280 patients with low operative risk, randomized to TAVI of surgery. And as you can see, despite the rate of structural valve deterioration is slightly, as unexpected, slightly higher for surgery, durability at 8 years, we only have 8 years, is not so different. So durability, depending on the age, might be a concern, but not so much. Regarding the risk of the procedure, I'm not going to extend on that, but we know on some aspects surgery is better, in others TAVI is better. In the end, is a discussion of the anatomical risk of TAVI and on the operative risk of a surgical aortic valve replacement. So these are things that are considered in the American guidelines, and I don't want you to read this because the letter is very small, but I just want to see you these arrows that highlight other things that have to be considered with the patient and within the heart team. So life expectancy of the patient, the age, we know that's on the guidelines, that's a guidance, it's not a holy word, it's just a guidance. Also concurrent cardiac conditions or other non-cardiac conditions, frailty, and this has definitely to be considered all around the lifespan of the patient. So probably our decisions within the heart team are going to be different for a patient of more of 80 years or a patient younger that maybe is still working and has different choices. And this is something that has to be discussed with the different views of expertise. And this is why we need different components in the heart team, and of course, cardiac surgeons. And finally, we have to move to that, and we have to do that because patients have also changed. And if someone is reluctant to work that way, patients are going to come and ask for that. And they're going to be informed, and they're going to be old but informed and wanting to have the best solutions for each one. Finally, considering Tavr, apart from surgeons performing themselves Tavr, surgeons are needed not only to take decisions in the heart team, because we need all points of view and all opinions to get the best solution. Surgeons are necessary on site to treat and to deal with the potential complications after Tavr that are not so frequent, but unfortunately they can occur, particularly in fragile patients and in patients with not so low risk. These are patients where complications are more frequent, but imagine you send a patient with very low operative risk to Tavr and there is a complication. You need somebody that can help and that can solve that complication. This is a report also from 2019, where they reported the reasons for bailout surgery after Tavr. And as you can see, there is a little bit of variability, and it depends a lot on the expertise of the site, as you can see here. So when it's a new site, the complications are much higher, but still in more experience, there is a rate of complications, of course. So finally, I just want to highlight, sorry, that was almost my last slide. Surgeons have a key role in the heart team according to our practice and according to the current guidelines, performing the procedures, for sure surgical, probably many centers also Tavr, but very important role balancing the opinions and helping to select the best option for each individual patient, and for sure definitely for solving potential complications, as I have shown. So definitely there's a plea for coordination and integration between professionals, between centers, with referring centers, and for sure there is a key role for cardiac surgery, even in the, not even, also in the era of TAVI. Thank you very much for your attention.
Thank you, Marta. I just want to ask you to interact actively. We have the chance to have Marta with us, which was involved directly in the guidelines document. So if you have any question with this regard, it's the moment, and this is where you can get the best answer. So please.
Yeah. Yeah.
I love the city which you hold the name Sitges.
I wish I hold it. It's not mine.
Thank you for your presentation. This is Dr. Mustafa from Geneva, Switzerland. So I will base my question on one personal observation. 2003, I moved from Turkey to Switzerland. And I started to work in a hospital. The cardiology team was led by Ulrich Sigwart, who was the pioneer for stenting. I remember in Turkey, we were operating 10-15 patients per week for coronary bypass surgery. And in Geneva, it was a huge impact. We were operating 1 patient per week, per 2 weeks. 2003, we operated 25 patients in total. And in those days, I remember something like a close echo, coronary surgery is over. It's a dead treatment. We will never need bypass surgeons in the future. We have stents. Now, 18 years later, all guidelines show us there are certain patients may be treated very well with the stents, but other certains with surgery. Now, before coming here, unfortunately, again, these 18 years earlier, echo I heard, guidelines underline, as you said, the age, 75, even 65 years, and older patients for TAVI. But I have 2 concerns, and I need your opinion. We don't have any clue about these young patient population, what will happen in the future, especially if they need somehow surgical aortic replacement, changing their TAVI valves. We have some case reports and very, very small case studies. And if they will not be operated for certain reasons or they will not ask, what about the Russian baby doll procedures? How many big series we have? In order to tell to the patient, they are sailing to the horizons which is not really clear. Do you think we are making big scale experimentations on our patients if we are not sharing these responsibilities openly? And I don't know, looking 2003, we don't have any clues how many patients passed away if they would have a chance to be operated with current guidelines, coronary bypass surgery. This is my concern. Do you think it's a little bit early to make these huge proposals for all the countries, all the patients, and especially, as you said, unfortunately, I don't want to understand like that, but many cardiology friends will tell this, age is used as a criteria, which should not be. Thank you.
Thank you. So I think the guidelines are guidance, are not and are recommendations, and we have to keep them in our area and with a specific patient. And this is why it's so important to discuss things with different opinions and within different expertise. I don't think we should send to TAVI all patients above 75 and all patients to surgery below 75. So I don't believe in that single cutoff. I just think it's a recommendation. And of course, we don't have evidence for all the things that you're asking, no? But we start to have evidence. And also, this is a reality. Patients come to us. It has happened to me, and for sure it has happened to you. Patients 60-year-old, I fear operation. I don't want operation. I want a TAVI. That happens. And you have to have solutions, not to provide the TAVI, but maybe not to this patient because this was a low-risk patient, but maybe for others you need to discuss. And I think we have to make really different approaches for different patients. So I'm not saying that the patient has to decide, but we have to ask for the opinion, we have to share, and maybe there are some controversial proposals on young patients, TAVI, and there we improve the extraction of the TAVI, and then we do surgery. We don't know. There are many things that we don't know. What I know for sure is that surgery is not going to disappear. And I am a cardiologist, so I can defend that.
Do you think there's a bias?
Quickly, please.
Asking the cardiologist, 60 years old, and I'm scared. It's normal. I'm scared also.
Absolutely.
But do you think the cardiologist, instead of giving an advice and guide the patient properly, there is a bias because this is the treatment used by this team, and what I realized in my practice, after seeing a patient giving the solution and letting them to digest, many patients were refusing surgery. They may understand 95%.
So for sure we all have a bias. We are persons, we are humans, and this is why it's so important for each center or each valve center to have its own heart team, to have a consensus on what should be done in each patient.
I mean, and Marta, I think we should highlight the fact that guidelines are not responsible for the shift or malpractice that could be applied here and there. And it's up to us also within every center, within every country, within every society, and this is why we are here together, to be sure that, for example, the heart team discussion is respected and not only a couple of lines which are written here and there. This is really very important. And all the question is there. The guidelines didn't say that we have to put the TAVI in all patients above 75 years old. They said some of them, and this is where we have to be really present. And anytime I have this opportunity, I will say it. I think cardiac surgeons failed for ages now to show how good they are and to show the benefit. We have been also using valves that have been not assessed for a long time, and we still do it. And I think this is what we need to change. If we want to claim to be better, we have to be at the top. This is, I think, the way we should do it. So thank you again, Marta. What I wanted to say also is I'm going to start my talk now, and what has led to generate these guidelines is a sum of evidences, both from clinical data that has been published, but also some improvements from the devices and iterations and improvements in our hands also that made us better, no?
Yes, yes.
Good. So it's my turn. My talk is an extension to what Marta has been sharing with us. So usually, correct me if I'm wrong, Marta, I'm wrong, when you get together to do the guidelines, you look at the data published and the quality of data published, and based on them, you come out with the guidelines, which are not a holy Bible, correct?
That's it.
They are just guidelines. They are here to show us the way. And some people are believers, some others are not. And the same for our practice. So I want to focus on a couple of key elements, I would say. One of them is the durability. Of course, there is a big question. Should we start by doing a TAVI and then operate on the patient, or operate on the patient first and then do TAVI? We don't know. And then how far can we go in the TAVI selection and indications? We need to generate some data, and this is based on the durability mainly, but there are some other key factors. We will be talking about this later. But durability is one of the dots that we are looking at, and we cannot align or get together all the dots looking forward. I mean, we have to give some time to show us if you're doing well or not. This is the history of medicine in any way. But what we know is that we have some signals that we could criticize, of course, but they are here. They are when we have to look at them. So I will not go through all the slides, but if we look at the Notion, for example, trial that has been recently updated at 8 years with this paper published in European Heart Journal that Marta showed us, it showed that although there is no difference in terms of structural valve deterioration between TAVI and surgery, the TAVI patients that have been implanted 8 years earlier are still there, and they didn't show to be doing worse than with surgery. And we have been able to see in this randomized trial similar rate of all-cause of mortality and stroke, and for patients at lower risk for Tavr or Savr, both of them. So you can question yourself in a patient in whom you can do both, which one is more suitable to do open heart surgery, have a chest open or even minimally invasive and be operated on, or just going for a procedure that go fast. I'm a cardiac surgeon, but I think we have to face the truth and look at these questions very calmly but very accurately. And of course, I would tell my cardiologist colleague, okay, we have 8 years follow-up, but look at 5, 6, or 6, 7, and 8 years, the number of patients that we are following, and this is where you are right when you ask your question, is not consistent. We cannot compare or base any change or any shift based on 80 patients and then 40 patients that have been followed. This is not a good science, I would say. But they are signs that we should follow. If you look at this data from the TAVI, the Italian registry also, and you look at 8 years also, we have the same signals. There is no early degeneration when you compare self-expandable supraannular implant, so the Evolut R, for example, in comparison with surgery, which is even doing better than the self-expandable. So, of course, it's not big enough, again, I say it, but they are positive signs that should convince us that probably there is something very positive happening there for the patients, for the appropriate one, if the selection obeys or obeyed to the heart team consensus. And this is really very important. So we cannot ignore it. It happens and it exists. This is one of the latest meta-analysis with all the limitations that we may opposite to the meta-analysis, but this is a real one. 10,000 patients almost, 9,388, using both they integrated and they looked at balloon expandable, self-expandable, but also surgical valves, and this is a consistent number. But this meta-analysis is really well-driven with all the best standards of doing a meta-analysis, statistical ones, and it shows clearly that self-expandable supraannular TAVI, like Evolut R, for example, is doing better than surgery, which is doing better than balloon expandable when you look at the durability, for example. So this valve showed, as you can see, it's very easy to read that self-expandable is doing better than Tavr, and Tavr is doing better than balloon expandable when it comes to compare mortality, stroke, and also at this stage, durability. So again, we have signs that shows us that this is not a jungle. It's going too fast maybe, but it is a reality. So at 5 years, supraannular self-expandable device demonstrated for lowest risk of structural valve deterioration, and this is really very important. This is what we base on our reintervention or not for this group of patients. And that's why we can say valve durability for these supraannular valves are found to be statistically superior to even some surgical valves that we are using. If we look at 2 years Evolut low-risk trial, and this is very important, of course, this low-risk trial results have been published immediately in the New England Journal of Medicine, and we all were waiting for the 2 years results, and we are now waiting for the 5 years results, and it shows that there's a plateau. There were no difference at the beginning in terms of mortality and stroke, and there is no difference after 2 years, and hopefully there will be no difference, not to please us or to please the cardiologist. It's good for the patient that there's no difference. Also what we see is that the hemodynamic changes in terms of gradient and EOA are not changing. It's stable over time, although again, it's only at 6 years, but at 2 years. But here we will have more patients with a good follow-up coming from a randomized trial. So I want to also highlight the fact that there is something that we didn't always look at in surgery, especially in women, for example, with small annuli, is you do bioprosthesis, and we used to insert easily a 19 valve diameter, whatever the valve you want to use. And I remember Hendrik has been talking about this a couple of years ago. He said we should stop doing this. We should not accept to put a 19 valve as surgeons in a lady, because we know that this generates mismatch. And sometimes, and not sometimes, it has been shown, you can see it here, that moderate to severe mismatch impacts not only the mortality. I mean, okay, we can accept the mortality of someone who's 80 to 85, but in younger patients, this is not something we can accept. And in that case, the question that we should ask ourselves, if we cannot implant a 21 or 23 surgical valves, if TAVI can do the job much better than us, why don't we do it? This is what we need to look at. So mismatch is a reality. Mismatch is a hemodynamic measurement, and mismatch has been assessed and certified for years from surgical literature. We have to respect this. And more than hard outcomes, stroke, mortality, there is something very important, which is readmission. I mean, we are in a society now, we look very carefully to our quality of life, and being readmitted after a surgery or a TAVI on a regular basis is not something that we would like, not for our eldest and not for us tomorrow. So I think if we have a solution with a valve that has demonstrated for 8 years a good follow-up, good durability, less gradient, we should use it. And there are only, I mean, to the best of my knowledge, only 2 valves that have been followed for more than 8 years, and Evolut R is one of them. So we have to be very careful in which type of valve we select. This is the problem with TAVI is also which valve you select, which valve you use. So in conclusion, I would like to say that similar rate of all-cause mortality and stroke for patients at lower surgical risk undergoing TAVI and Tavr has been assessed and shown from the NOTION trial, which was the first non-sponsored study to randomize surgery versus Tavr. Although in this study also, some surgical valves that have been used are not the gold standard of valve that you should have been using. From the meta-analysis I showed you, the conclusion was valve durability for supraannular Evolut R platform has been found to be statistically superior to at 5 years versus surgery, and surgery was doing better than balloon expandable valves. The low-risk trial showed that the Kaplan-Meier death or stroke also at 2 years was not significantly different between surgery and Evolut or implant, so it's still the same. But Tavr was superior to surgery in regards with valve hemodynamics, PPM, and we, of course, my final word is to say that we need a longer-term follow-up to evaluate these differences and the impact on the patient. And I think we are in 2021, and we need more and more to apply a personalized approach, and this is what is suggested by the guidelines, and not have an ad hoc approach, and anything aortic stenosis should be treated by TAVI or surgery. I think we should discuss all these cases day by day, and I think heart team is the only guarantee, providing that we can protect this heart team concept and make it survive. Thank you very much. If there's no question, I think we should keep on to be in time. I just want to say that the guidelines and what I've shown you has been able to be shared with you because we made a lot of progress, not only in terms of iterations, but also in terms of technique. And this is what Martin's going to show us here. We had 2 problems, or 3 problems, I would say, in the early days of Tavr. You can keep the question for the end, please. One is the predictability. And this is something that Martin's going to show with you. When you put a TAVI in a patient, would you be able to put it at 1 or 2 millimeter? Would you be able to avoid paravalvular leak? And would you be able to reduce or not have a pacemaker necessity? And this is now something that we can achieve based on a careful selection, but also some technical tips and tricks that Martin will show us. Martin, your turn.
Well, hello, and thank you for the invitation. So I'm going to talk about implantation techniques to help minimize pacemaker rate and paravalvular leakage, so to improve the outcome of the procedure. These are my disclosures. So I will talk to you about the access site profile, very important to avoid groin complications, the Cusp overlap technique for implantation, commissural alignment to allow coronary access, and the clinical data we currently have so far. The Medtronic valve is available in 4 sizes, and this is important to say that it's for small annuli also available as for very big annular circumferences, which is important because other platforms does not always allow to treat patients with a big annuli. However, the profile of the valve is small, so it allows to have a puncture also in tortuous vessels, also in small access from the transfemoral side, which improves, of course, the safety profile of this valve system, and you can now see this in comparison to other platforms. I think it's important to know that not all sheets stay at the same size. If you put the valve through, some sheets dilate and therefore have effective bigger outer diameter than they are labeled. Coming to the Cusp overlap technique, what is it? Importantly, this is a kind of a different projection where you can implant the valve with a better sight on the cusps and to target the implant depth in more detail. As you know, there is a specific landing zone for every device, and the self-expandable system presented here has a landing zone between 0 and 6 millimeters, which is kind of between node 0 and node 1. So the higher the implantation, the lower the risk of pacemaker implantation due to the mechanical interaction with the AV node. This is a typical standard projection which shows all three cusps. And normally, this can be, in a lot of cases, in a typical AP or projection of the angiographic system. However, as we know, there may be in this AP projection, the delivery system has a different angle than the aortic valve, and there are other projections which can overlap the optimal projection of the delivery system with the annulus. So we have a better sight of both the valve and the annulus, and this can be obtained by the so-called cusp overlap technique. How we can get there? The rule is to follow the right cusp. From the typical view, we have to turn the angio system to LAO, typically, and to caudal, and then we can have this cusp overlap technique. There are different publications out, so you can easily access them and the literature and try to get practice in obtaining the perfect view. Of course, you get an estimation of this view via pre-procedural planning, so you will know which is your cusp overlap view, and then you can obtain it with the angiographic system and check it with fluoroscopy. So importantly, the cusp overlap technique allows the elimination of parallax of the delivery catheter. The delivery catheter is more centered in the aortic valve, and the deployment can be done in a true coplanar view. And for us, so the potential benefit is to have a better sight of the valve and to allow a higher implantation of the valve. And this has also been described in the literature. So you can use this view and try to include it in your daily practice, but of course you have to be careful not to be too high to avoid valve embolization. The other thing I want to point out is the so-called alignment, commissural alignment. Typically, if you use during the implantation the flush port at 3 o'clock, then the valve probably will be aligned with the native cusps. Of course, this is only an estimation. This is not true in all patients, especially in patients with a bicuspid valve. But with gaining this alignment, the access to the coronary can be better preserved for potential interventions which might be necessary, especially if the valve is implanted in younger patients where the valve will be in a longer time and the patients can develop coronary artery disease even after implantation of the valve. And here you see the orientation of the system going through the aortic annulus with a stiff wire, and this Landerquist wire it does also improve stability of the valve. I will show you now the data from the Optimize Pro clinical trial, which evaluated these techniques. There is still a pacemaker. There is still a pacemaker implantation rate of 17% in self-expandable valves, which is a kind of a aim to reduce this pacemaker rate to improve the overall results of this device. So this study included severe symptomatic patients with aortic stenosis, and these patients were undergoing implantation with the so-called optimized procedure, and the endpoint was all-cause mortality and stroke after 30 days. So there was a roll-in phase with 71 procedures in the main cohort with 100 patients included. So the patient received an ECG, a specific screening pre-procedural. And during the procedure, the cusp overlap technique was used. There was no ballooning performed except in cases where it was necessary, and it can be necessary in very narrow valves or a very tortuous aorta. anesthesia was avoided, and transfemoral access was used. Importantly, patients with a right bundle branch block, which we know from the literature, also from surgical experience, have a higher risk of developing a complete AV block during the procedure, and these patients were specifically monitored during a longer time after the procedure. And importantly, a Landerquist wire was used, which is a kind of a more stiff, one of the stiffest wires available to give more stability during this implantation in a high number of patients. Few patients were going to ICU. Most of them were treated with a step-down unit, and the median length of stay was very low in this cohort, so a kind of a optimized treatment, and the all-cause mortality was 0. Obviously, this is cannot be reproduced in the reality, but this was a very good and good monitored and well-performed trial, and the pacemaker implantation rate was 10%, so it came down to a lower number as we know from the literature. And aortic regurgitation was also low. There was no moderate or severe aortic regurg in these patients. Importantly, due to the outer pericardial frame, this valve has a lower risk for aortic regurg, and also the NYHA class improved what we would also expect. So that the Cusp, to the opinion of the authors of this trial, the Cusp overlap technique helped to improve the clinical results. So in summary, the 30-day outcome from this trial, this optimized PRO study was excellent, and this can guide us to improve also the TAVI program at our institutions to improve the results for the TAVI implantation. There was no pop-out observed in this trial, but also I have to say the implanters were certainly very experienced. So TAVI is not a simple procedure. Even if somebody tells you, just be aware, TAVI can be complex, and you should be trained properly and train your team properly, because adverse events can be mostly avoided. So, thank you.
Good, Martin. So Martin, I mean, we can say today that an Evolut R implant is not a freestyle implant anymore. It's standardized, it can be taught, it's reproducible.
Yeah, so I think there should be a very standardized protocol for TAVI. It's possible because TAVI is a very standardized a procedure which can be easily standardized, and it's in most centers it's done very often, so it can be trained properly. So you need protocols for training and standardization, and also what is also reflected in the guidelines, the TAVI should be performed in centers with a cardiac surgery on site and not everywhere where a cath lab is. And this is a very important marker for quality. We now see with the MitraClip, which is spread all over the small centers, that results are really going out because there is no big experience. In small numbers, we know it from surgery, small numbers are not good for quality.
Absolutely. Christoph, do you want to ask your question again? You're not upset?
Meta-analysis.
Yeah, one second. He's connecting your micro. Yeah.
Okay. Congratulations for the presentation, all the presentations. I'm Dr. Protoulas from Greece. Just to remind you that the meta-analysis, actually I had a presentation last week in my country, and I used the meta-analysis, said that total moderate severe aortic regurgitation intervention was more frequent in TAVI than Tavr.
Of course.
So, is not the gold standard.
No.
Till today.
No one said this. I agree.
I think the answer for the durability is the PPM, the patient prosthesis mismatch. So TAVI has perfect hemodynamics. We don't use the largest surgical valve, and this is the problem. Okay, thank you very much.
So I would like to make a comment also on this meta-analysis. As this is a surgical meeting, it's very important to compare the valves and not the procedure. So we should compare a self-expandable Medtronic valve with an Edwards valve, with a Magna valve, with a Trifecta valve. So we know, Paul Werner from my institution presented today, there are very big differences in durability in the surgical valves. And also the Notion trial, as you stated, had implanted valves which are already off the market. So they are not used anymore because they have a bad durability. We know that. So they were taken off the market.
Yeah, but I mean, go on, Christoph, please.
Another problem, at least in my country, is the DRG. DRG for TAVI is 10,000 plus the whole material. That means about 25,000. The DRG for surgical valve, the whole DRG plus the material is 10,000. So the surgeons cannot use the best valve, cannot use
Magna.
Let's say
Avalus.
not Tavr. I'm sorry, the best valve. Okay, let's say the best valve. This is the problem. Another problem. So I don't know.
No. I mean, you are absolutely right. But I mean, again, all this converge to one pathway, which is we need a hot team. We need to select based on the center and the practice differences what's best for the patient, but depending also on the experience and the availability that we have. So I just want you to, I mean, I'm not saying that TAVI is better than surgery. I'm just saying that as surgeons, we have to espouse the evolution of TAVI, and this is very important.
We need to accept the TAVI.
Absolutely.
Okay, to do TAVI with the cardiologist, definitely.
Yeah.
But at the end, I don't accept the position of every single patient that I don't want to have a surgery, because it's the same that if a patient has a COVID, I don't want to have intubation. It's not the same. The patient is not a doctor, is not a surgeon, is not a cardiologist. Just like to do something less.
Yeah, but this is a manipulation from some colleagues, and it's not the guidelines who are saying this. You know.
The truth is
this is the difference.
We are not the gatekeeper. Actually, my son is going to be a cardiologist.
Okay.
We're not so bad.
He's smart. So, Hendrik, it's your turn to show us really what Martin has been telling us can be reproducible.
And I think I want to go one step further even. It's hard, it's in the guidelines, and we just heard it, that the cardiac surgeons are part of the heart team, and that TAVI should only be done in centers where there is cardiac surgery on site. But I would go one step further. They have to be part of the procedure, and cardiac surgeons have to implant TAVIs themselves. Exactly. I mean, this is something that we also have to do in the future. It's not so difficult to learn. And we should just make it part of our own armamentarium, and then we speak differently. So that's one point. And we did this, of course, in Mainz, this Evolut R plus Pro implantation in the heart team with me as a lead operator. But it's nothing that we should see as a special case that was just taped for the symposium. We just do it every day. And there's Stenosis Character sitting, he's a cardiac surgeon, he does TAVI every day in his center. So that should be part of our armamentarium. So as a commented Live in the Box case, before it starts, I would just introduce the team because it was cut out. I mean, this is Stefan Bardeleben and Martin Geier, my cardiology partners, and I'm the guy on the left hand. And if you put on the tone, then we can just have the audio. And if not, I can do it from here. I know. Don't we have tone? Then, okay. So here we picked a 79-year-old female patient. She was a clear TAVI candidate. She was referred to Center for Acute Coronary Syndrome And in respiratory failure, she underwent PCI of her coronary arteries several times, and her Euroscore 2 was 6.47%, so not in the very high region, but if you would have seen that patient, it was a clear TAVI indication. And from that perspective, we did not discuss the surgical options too long. Here's a coronary angiogram showing stenosis that was then treated with PCI beforehand with good results. So you see the result after the stenting. This, of course, was done before the TAVI implantation. Here you see the valve in echo. We see severe left ventricular hypertrophy with a normal preserved ejection fraction and low flow, low gradient stenosis in this case with a 45/25 millimeter mercury gradient. But due to the reduced ejection fraction, we considered this being, and the high calcification rate, we considered this being high-grade stenosis, and therefore, of course, we took the indication. This is a CT scan, as you see, and she had a small annulus. And this is, again, a topic we have to discuss. What do we do if patients show up with small annuli? If she would have been an operative candidate, I would definitely have done a root enlargement in her, because implanting a 21 valve and this 21 to 22 sized annulus is not a good idea in the long run to avoid patient-prosthesis mismatch. Otherwise, she was a good candidate. We decided here to implant the Evolut Pro Plus platform. You might have seen that valve already. It's now the newest iteration with two advantages. First of all, we have the skirt in all sizes that really prevents pulmonary leakage. And it's a true 14 French system. What is, of course, especially in this patient, as you will see, an advantage because it helps with access if patients come up with small vessels. And in this case, we decided for the 26 valve, Pro Plus, that was then implanted. And we heard from Martin Andreas the way how to do it. And this is, again, shortly explained here. We used the Cusp overlap view. And that was very helpful for many reasons. First of all, we know that we can adjust. You put again my microphone again? Okay. So it's very important for the proper positioning of the valve. In that particular patient, it was also important because the patient underwent an operation of her spine beforehand. So we had a metal cage right in our X-ray views. So it was an additional advantage here to go for the cusp overlap technique, because then that valve could be much nicer displayed. And here's the 3-cusp view as we usually do it and did it in TAVI in the past. And then using this Remensio software, for example, you can already predict your C-arm angulation with cusp overlap, and that usually is an RAO caudal, as it was in this patient with an RAO 14 caudal 30 planned projection for cusp overlap of left and right. And that also then helps with commissural alignment, as we learned also from Martin. That plays an important role, and turned out in this patient that we could achieve this perfectly well. This is peripheral access, and as I said, these are small vessels basically, also a bit tortuous, and therefore we were very happy to have a 14 French system available. Here's her ECG with no special things, no bundle branch blocks, anything that would be of concern. And we always measure the length of the membranous septum. That was 7 millimeters here. That also gives us a hint on how high the risk of pacemaker implantation later on is. And now we are right in the procedure. So it was a puncture of the left groin that we picked due to the better access. First we implanted the 14 French sheath. This is, of course, regular TAVI. We went for the right groin for the pigtail catheter. We usually do it through the radial artery in this patient. Also, again, to her vessel problems, it was more safe to go from the contralateral side with a pigtail. And this is, well, the usual things you do. And here you see with the problem. I mean, if you come up with this image, then, of course, TAVI doing it the regular way with the 3-cusp view is pretty difficult because you have no idea where you are. And then, of course, we're very happy that the cusp overlap gave us this view, basically, more or less. and had a much better projection of the valve. So this is having the pigtail in the aortic root. Then, of course, we do a root angiography, and then the passage of the valve. There is a pacemaker lead that we, of course, always have as a passenger pacemaker in every patient. And we use it with implanting the Evolut Pro Plus valve frequently, not in rapid pacing, of course, but in some kind of faster pacing to just have the amplitude of the blood pressure wave in a controlled fashion. So this is the retrograde passage of the valve with the soft wire. That was not a big deal in this patient. You're just forwarding the catheter in the ventricle. And here you see also the stents in the coronary arteries quite well. And then we exchange this for stiff wire. This is all regular TAVI implant routine. But before, of course, place the stiff wire, we measure gradients and hemodynamics. I think it's important to do this always beforehand and afterwards. And here you see there is a gradient of about 30 millimeter mercury due to the low flow, low gradient situation, and otherwise regular pressure curves. And then here, the valve was crimped, of course, and we always check for correct crimping under fluoro. Here the valve was perfectly crimped. And on the top you see also the head marker already. That is important during implantation to achieve commissural alignment, as we will see in a minute. So I'm sorry that we have some pauses here in the video because it was the audio was taped too, and I don't remember exactly what I said in that very situation, so I cannot repeat it word by word. But I think we had some discussion about the gradients and stuff. So, okay, now we go forward and place the stiff wire. I think there are various choices of stiff wires, and it's not so important, again, which wire to use. Should, of course, be atraumatic. And then we would take out the sheath, of course, and replace it with the integrated sheath in the Pro Plus system. What is, of course, one of the advantages with the Evolut platform, I think, that we have this integrated sheath. But as you can see here, sometimes, since the tip of it is not as smooth as a dilator is, it's sometimes not easy in small vessels and in calcified vessels to bring the valve forward. So here we had, and we did not cut this out actually, we had some difficulties in bringing the valve forward. And then I would not, as we did here, I would not force anything. If there's a resistance, then you should not just push and hope for the best. We took the valve out again and did another pre-dilatation. I think this is the safest way to do. And with a dedicated dilator, this pre-dilatation is very easy, and then it was just easy to forward the valve and get it in. So now we are at the arch, and arch passage, of course, always important to watch, although visualization is not this easy in this particular patient. And now it's all about the head marker. You know, we start out with the 30-degree angle of the flush port, as we've learned from Martin, in order to achieve commissural alignment. And we could also see that the head marker is on the outer curve. And this should stay there while you have the passage around the arch. So we go for an LAO to see the arch in the best view and to see that there's a proper passage of the valve. And then you go slowly but steadily forward, and then somehow the valve falls into the anatomy. And at this moment, we would now go for the cusp overlap view. There was an RAO caudal. Because from the very start, we want to achieve the best implant height. And you should also consider that the valve is diving a little bit into the annulus when you start deploying it. So you can start a little higher, actually, and take profit of this somewhat natural movement of the valve. And this is what we do now. So we start a little higher. You see the pigtail is in the nadir. And we intentionally start a little bit higher with the implant, knowing that the valve would come down. And you see also there's not much wire support, so there's no need to really push the valve upwards when with placing the wire in the ventricular apex. It's more or less a natural movement of the valve during deployment. Hemodynamics have been stable here. There was no problem. So, and now we start opening the valve. And you see there's some pacing, just to achieve proper hemodynamics. So we are a bit high here. So if you see this, then you can push slightly forward to bring the valve a little deeper, but not too deep, because we definitely want to achieve the highest possible implant. And while moving forward, you see that the valve is somehow coming down, and now we are in perfect position. Right? So this is the perfect height. From that time point on, you should take care that the valve does not go deeper. And then when the valve starts flaring, it's time to do a root shot to confirm that we are in the correct position. That looks all good to me so far. But of course, at this moment, we have to check. Hemodynamics went down for a tiny bit, and then once you are high enough and the valve starts moving again, then you have good hemodynamics again, and this is now being checked by angiography. So, yeah, and I think that looks very good. I think we have achieved a proper implant height. It's not safe to go much higher. It's not necessary to go any deeper. So at this moment, since there was also basically no relevant regurg at this moment, even with the valve not fully deployed, we just went forward. And we're happy with that implant height and released the valve. Bit of discussion. I don't know exactly what we were discussing at this moment, because I think everything looks good. But yeah, and then what we do is that we take the wire a bit higher, that there's no wire push. And then during the release, you have a bit push on the system, and then you just release. And you see there was no movement of the valve, any millimeter in the annulus. That just stayed proper in place. And then, of course, you take care that you have good removal of the delivery system without displacing the valve. This was pretty easy in her case. You bring the system in the descending, and then you just close it. Under fluoroscopic control, like now, and then you can take the system out and exchange again for the 14 French teeth to do all the further evaluations of hemodynamics and then, of course, we exchange the stiff wire with another pigtail. Here you see there's no gradient at all anymore. We also see no signs of regurgitation with a very good and low end-diastolic pressure in the left ventricle. And then, of course, this is concluded with an angiography afterwards to really check for any kind of regurgitation. What we have not seen here, maybe you've seen the ECG, is any change in the conduction system. So there was no development of bundle branch block or anything. So the patient was very stable in this regard. I think we are discussing exactly this point now, that there's no change in the ECG. And then this would be the time for the root shot. We then again went for the cusp overlap view. Took down the pigtail of the ventricle, of course, to not have any valvular regurg here. This is why the pigtail is now parked in the descending. And what you can also see here now, this is the cusp overlap view, and you see the C marker on the right-hand side. This is exactly where the commissure is between left and right, so it's perfectly commissurally aligned. That's always important to have a look for. So for future coronary interventions, this valve would not have any problem. And she had coronary artery disease, so that's of course something that we have to have in mind and check. So I think now finally we do a root shot. And this is perfect. There's no regurgitation at all. It was also later on confirmed by echo. And no gradients, no bundle branch block, commissural alignment. So everything we wanted to achieve, we could achieve in this case. It was not an easy one. And I think my final words are thanks to my heart team, because it's really also a sign of trust of the cardiologist, and I'm only there for half a year now. Let you stand on that side and implant a valve in a complicated patients, and this is how a good heart team works. And if you work in such a way together, then the discussions next day when it goes about patients and this and that treatment direction are much more easy, because the cardiologist would also trust yourself that you have an opinion on TAVI, because you know what TAVI means and is. And you also have a different opinion on TAVI. You don't see it as your enemy anymore, but as your friend, and as a very good option for a subtype of patients that take profit. And this patient definitely was such a candidate. And yeah, with this, thanks very much for your attention.
You're a cardiologist or a surgeon?
Huh?
Are you a cardiologist?
I'm a surgeon, and actually I'm a dedicated surgeon, and I love to do surgery, and all kinds of surgery and minimally invasive stuff and all that. TAVI is just a hobby, but it's a nice hobby.
I mean, you do it like a cardiologist. That's what I was saying. This is a joke. What do you think, Marta?
I think it's very nice.
No, this is your voice. I
Okay,
think. Yeah.
I think this is the way to go. I mean, I think what you said at the end, that performing also the intervention is important. No? From my side, I am an imager, so I like to be in the OR with surgeons. I learn a lot on the valves in the OR, but then in the cath lab it's very important because you see the devices. So this interaction between the interventionalist and the cardiac surgeon, I think, is very necessary for afterwards see what they can do, what you can do together, no? And I think that's very important, and I think that's the only way to go, because fighting between each other, it's not going to succeed.
But here we've seen the best practices with TAVI today, and this is with such way of implanting we can achieve really the best treatment for patients. Otherwise, we will be below the average. I mean, it looks easy, but as you said, you aligned the commissures, you did the Cusp overlap, you looked at this membranous septum, and this is something we didn't talk about. I mean, so you adapt the depth of implant based on this. Actually, it's a hobby, but it needs many boxes to be ticked, and this takes some time of preparation and I mean, discussion. You don't do this when you do surgery, but if you want to do good TAVI, you have to do this. This is as easy as it is.
Yeah, and I think the other way around. For example, for intervention, cardiologists, I tell them you should go, if they are doing valve repair, no, like clip, wherever, you should go to the OR to look at the valve and understand, no, because I think that's the key.
So I just want to close this session now. First, thanking Medtronic for this opportunity to share with our surgical community the latest progress. For Marta for the guidelines, and thanks for coming with us. For Martin to describe the technical tips and tricks, and you for the beautiful demonstration. I think we can say that implanting an Evolut R today has nothing to do with has used to be done 10 years ago. It obeys to some gold standards and best practices, and if we respect all these steps, we do the training that we should do and the work that we should do, we can offer the patients a therapy which is fantastic and which is allowing today 8 years durability probably, and beyond hopefully in the future. So this is an open invitation again. I mean, we are convinced that surgeons should espouse this TAVI evolution and percutaneous in general, and this is the only way to have an effective discussion also within our team, because if you don't know, you cannot talk. Knowledge is power. So thank you very much.
Thanks.
Thank you.